Okay, so I see that unfortunately Miriam Barry is not available at the moment. Hopefully she'll be joining us soon. But I think we ought to get get going because it looks like we have a nice sized audience and we want to begin. So I'll introduce myself. My name is Shlomo Lieberman. I am lucky enough to be the Director of Mental Health at SBH. And tonight I have the honor of moderating a discussion between two esteemed professionals, hopefully three esteemed professionals and colleagues. Let me introduce to you our panelists. First, Dr. Edward J. Gindi is a pediatrician and board certified allergist and immunologist with over 35 years experience in private practice in Brooklyn and New Jersey. He's affiliated with NYU and Maimonides Hospital. He has spoken many times for SBH Medical Division and is always willing to share his expertise. Thank you, Dr. Gindi, for being here.
Welcome.
Okay. Next, we have Dr. Benji Stern, is the Director of Pediatric Adolescent Professional Psychology and has extensive specialized training in the evidence-based treatment of children and adolescents and young adults in the area of OCD, including PANDAS, anxiety, depression, trauma, ADHD, emotional dysregulation, parenting training, and social skills deficits. He has years of experience in facilitating positive changes, brighter futures, and happier homes for the children, teens, and young adults of our community, including his earlier career experiences as the psychologist at Magen David Yeshiva. That's when Dr. Stern and I got to know each other many years ago.
That's right.
Okay.
Thank you.
So I want to thank you both for being here. I look forward to learning because I'm definitely not an expertise or very well-known in PANDAS, and I look forward to learning a lot tonight. Dr. Gindi, why don't you give us our introduction to what is PANDAS and what does it look like, and help us with a little bit of a medical background, if you can, please.
Okay, you're well. Thank you, and I want to thank SBH for allowing me to join. It's my honor to share my expertise and my experience with this very important condition, which frankly has been been recognized more frequently of late than in the past, and a lot of parents are coming in thinking that their kids have PANDAS. It's quite rightly so, and sometimes very often confused about what PANDAS are. So hopefully we'll be able to give you some things hooks to hang your hat on, and some criterion to help parents try to figure out whether their child indeed does qualify for the diagnosis and treatment of this very important condition. So to get started, I think we should start with defining our terms. Okay, so PANDAS, P-A-N-D-A-S. So let's go through each one of those letters of the acronym, and that will in itself enlighten us a lot about the condition and help us figure out if any particular child indeed does have PANDAS or not. So P stands for periodic. So periodic means it comes and it goes, it waxes and it wanes. It's not something that's been, it doesn't sort of stay steady all the time. It comes in and goes. That's what periodic means. Acute is probably the most important term in this acronym. Acute doesn't mean severe. A lot of people think acute means amazing. Sudden onset. In other words, on a Monday the child is fine, and on a Tuesday the child is not fine. Something really unusual is going on with this child's behavior. I always give my example of I have a kid on a Monday who's perfectly fine, and on Tuesday she starts saying the berachot, they're like Baruch, 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 Ata, 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 and this happens. This is something that, you know, and they just bring the child in because the child is not acting acting in a very unusual manner. So it's an acute sudden onset in a child who had Miriam. Okay.
Hi, give me a minute. I gotta get to my car. It's
okay,
little technical difficulties today, but I will be joining you shortly. So
okay,
I will be with you.
It's a little loud.
Okay.
Can Shlomo, can you mute me? Shlomo, if you can mute me, that would be great.
So, I'll continue. I'm getting an echo.
Yeah, I'm trying to,
I think she has to.
yeah. Um, Miriam, I think you have to log
Yeah.
off for now. Can you
Oh,
log off and
Okay,
we'll let
so,
you back
all
in?
right, can you, right, yes, just, can you, are you able to get me out? Because I don't know how to do that.
Um, no.
I'm just going to log off. Okay, I will log off. I'm going to close it. Let me see if I can get out. Okay, I don't know how, so I'm going to just close it out and I'll
Okay,
join again.
thank you.
Okay.
oh,
I apologize.
that's good. No
Oh,
problem.
there we go.
So
Okay.
we said did the A, the N. So the N is neuropsychiatric disorder. So what is a neuropsychiatric disorder? So patients, there are many, many of them, but the ones that are classic for PANDAS, and I'll go through them because we see them all the time. I'm not going to say every day of the week, but we see it very frequently and commonly. The neuropsychiatric disorders that are associated with PANDAS are first, tic is one of them. A tic is a repetitive just so that parents understand what a tic is, it's not a habit. It's a repetitive, uncontrolled muscle contraction of any nature that the child has no control of. So a common tic could be an eye blink or a shoulder going up, or stuttering. Severe stuttering can be a form of a tic. But I personally don't usually use tics alone as a criteria for PANDAS. I think they have to come in along with some other kind of behavioral disturbance, because there is something called transient tic disorder of childhood, which is very, very common and is not always, not associated with strep. But if a child does have a sudden onset of a severe tic, they could come in for a throat culture and make sure that there's no strep. And if there is nothing and there's no other behavioral disorder, I tend to pass those. OCD is really a very, very common one. OCD stands for excessive compulsive disorder, and it could be, as I said, repetitive thoughts, repetitive actions, repetitive questions is very common, especially in the age group in which PANDAS is the most common. Now, the age group of PANDAS, most of the studies are saying between 3 and 12 years of age. It can be early pubertal. Sometimes you see them in teenagers, but really 3 to 12 is the most common age group. So you will get repetitive questions. Kids will ask the same questions over and over again, and they know the answer, and they just can't help themselves. So OCD is very typical one. The next one we see a lot of is ODD, oppositional defiant disorder. You have a kid who otherwise is normally a normal kid who sometimes complies and sometimes doesn't comply with parent requests, and now he's oppositional. Everything you ask him, it's a no, it's a fight, it's a battle, and it's a very extreme onset of behavior. The other one we see very commonly is phobias, like, we're not talking about a simple, we're talking about like a really severe, school phobia is like a big one where you really can't get the kid on the bus or the car service, or not the car, I mean you can't get the kid on the bus to go to school. You try and he's just kicking and screaming. You need 3 people to put the kid on the bus. And for some reason, just there's no explanation. This child just has a school phobia. Phobias is very common. And anxiety. Anxiety is quite often going to be like a separation anxiety, separation for the parent, but extreme anxiety. So these are disorders, not this. There are other conditions that are on the list, but in and of themselves don't really constitute a PANDAS condition, like a bedwetting, those kind of things. Mood disorders, extremely moody. ADHD is also on the list, but that brings me to the next thing is sometimes the sudden onset can be in a child who already is a vulnerable child with a vulnerable nervous system. So they may already have some anxiety or some ADHD or some of these particular conditions that we discussed, but there's a bump up in the condition, like a really severe acute exacerbation of the condition. Those kids can also be considered as having PANDAS, and probably should have it ruled out. So so these are disorders. These are not just dysfunctions. When I say disorders, I mean they got to be severe. It's not just like a general, up and down, child having a good day, child having a bad day. But these are very severe, usually very, quite severe. And they are associated with strep. What does that mean? So disorders associated with strep. So it can be actually a child who recently had a strep, currently has a strep, um, or is going to get, believe it or not, like if you bring a child in and the child doesn't have a sore throat, and you do a culture, that could mean that the child is in the incubation phase and the strep symptoms haven't manifested themselves yet. So they are basically carrying a strep, even asymptomatically, and they may or may not get symptoms of a strep throat, which could be fever, headache, stomachache. A lot of people are very familiar with a strep throat. So this could be at any point in time along the continuum of when the strep infection occurs in the child. The other thing I want to bring out before I go into a little bit more detail is there's a condition called, and if you Google PANDAS, you'll see PANS. So I think we should mention PANS is really more of a general term. It's periodic acute neurologic disorders, and they could be associated with other infectious agents, the most common of which is mycoplasma. So mycoplasma is a not really well heard of infection in layman's terms, but doctors know about mycoplasma. Is an infection that often symptomatically will produce bronchitis, pneumonia, respiratory illness. But sometimes you don't really get a bronchitis or pneumonia with a mycoplasma. You can get something as simple as a cold and a cough, and the body fights it off on its own. And that actual viral illness, which you think is a viral illness, was really a mycoplasma, and that can induce a PANDAS-like reaction we call a PANDAM. And believe it or not, this is very common. It's not uncommon at all to see this. So when we do the workup with the blood work, we always look, I personally, I don't know about we, but I personally always look for this mycoplasma infection. I want to back up for just a second and just give a general introduction of PANDAS and the history of it. I mean, this is a condition that was first described 25 years ago, which is not a long time. And it was very, very controversial for quite a long time. And even today, it seems to be somewhat controversial, although I don't even know, I'm trying to find, if it's officially recognized by the American Academy of Pediatrics. I'm not entirely sure. I tried to figure that out. I tried to do some research, but there are a lot of associations today that deal with PANDAS. And as clinicians that are on the front lines, we see PANDAS without a doubt all the time. These are kids who are, again, sudden onset, have either a positive strep test or a recent history of a strep, and they are suffering really greatly. So but you do, in this condition, we start to enter into murky waters. What I mean by murky waters is that some of the stuff we actually know, and some of the stuff we theorize and we think and we have our best guess and we use our clinical judgment. What I mean by that, I mean, like when it comes to mechanism of disease and treatment of disease, we're starting to enter into murky waters. And this is where the art of medicine comes into play. So what happens is doctors like evidence-based medicine. What do we mean by that? I mean, like you do a study, you look at 100 patients, you compare them to 100 people that don't have the disease, you give medication, and you say, oh, this medicine works because X% got better with the medication, and in the placebo group, so they didn't get better, and then we know the medicine works. Unfortunately, in PANDAS and PANDAM, we don't have these kinds of studies when it comes to treatments. The simple reason is that there are many, many, many variables, and it's impossible to control for all the variables in order to determine what medicine works and what medicine doesn't work. What do I mean by that, many variables? Well, first off, did the child have strep or not? How was the strep diagnosed? Was it a rapid strep? Was it an overnight strep? When was the strep in comparison comparison to the onset of the illness? How severe was the illness? Did the variables of like OCD, all the different neuropsychiatric illnesses, how did it get better? Can we measure if it got better? A lot of these things are not measurable. So bottom line is, when it comes to treatment, we as physicians have to learn from our patients. And this is what it means to be a clinician in any day and age. And as much as we have AI and we have all these computers that help us, we still have to be clinicians, and we still have to work with the art of medicine. And this is where Somebody with a lot of experience can say, well, I have experience, or I'm reading an full anecdotal. And as doctors, we share our experience with each other through literature and studies as much as we can. And we build a base of data in order to go forward and try to offer our patients some kind of hope and some kind of treatment, again, with some limitations of expectations, because we can't say with an absolute certainty at 85% this medicine is going to work and 25% it won't, et cetera, et cetera. We don't have that data for our patients, unfortunately, in this condition, again, because of the limitations that I described. So I want to back up for a minute and get into a little bit of scientific, if I can, explanation of why is a child experiencing neurologic and a brain dysfunction because of a simple strep throat. Like, what's the connection between a strep throat and a central nervous system dysfunction? It seems like it's like, apples and oranges. It doesn't seem like one would be connected with the other. So what we do is we draw upon our knowledge base that we have in other diseases. So we know for a fact that strep and other infectious agents, viruses, whatnot, when the body fights off these viruses, the body recognizes a protein on the surface of the offending agent, and sometimes the antibody that the body produces against this strep infection is recognizing not only the strep protein, but other proteins in the body that mimic the protein on the strep. In other words, the antibody is not super specific enough, and it cross-reacts with other proteins and other organ systems. So we know for a fact that this happens because in rheumatic heart disease, rheumatic fever, rheumatic heart disease, which is the number one reason why we treat strep to begin with, and rheumatic heart disease is the incidence has gone way down to the point we don't see it anymore almost, because people get treated for strep. But if you allow the body to produce antibodies against the strep, those antibodies can attack the heart. So they can attack the heart and cause a dysfunction in the mitral valve, et cetera, et cetera. So we see older people, when they go to their cardiologist and they have a problem with their mitral valve, very often they have had rheumatic heart disease back in the day, but we don't see it. Yes.
So I just wanted to clarify, because what you're saying is that the mental illness symptoms, the psychological symptoms seem to be as effect of our own antibiotics, our own
antibodies
fighting the wrong proteins.
So that's what I was getting up to. Yes, you're one step ahead of me. So these antibodies that haven't been shown with any real, as I said, evidence-based medicine, but the theory is that they cross-react with proteins in the basal ganglia in the brain, and that cause dysfunction in the central nervous system because they're not super specific against the strep. They're actually attaching to neurons in the brain and causing the brain to dysfunction somewhat. That's one theory. I don't think that's been proven, but that's a plausible mechanism, because we know that mechanism exists in other diseases, specifically in rheumatic heart disease, and I can go through a whole list of them, but I think you guys got the concept of it. A lot of times patients come in with, like, the kid is limping and the lining of the knee is inflamed and they had a strep throat. Again, it's the same concept, is the antibodies are attaching to the lining of the joint, causing the kid to limp, et cetera, et cetera. I can go through a whole list of them, but it's not relevant really right now. The other very important, the other important mechanism, which I tend to believe is probably just as important, if not more important, is antigen-antibody complexes. What that means is when the body you have the strep and you have the antibodies, and they clump together and they produce like garbage. Now it's garbage. The strep is dead, and the antibody is attached to it and is floating around in the body, and the body has to get rid of this somehow. So normally the liver does it, the kidney gets rid of it, and sometimes these complexes get stuck in the kidney and cause kidney disease. And we know for a fact, because there's something called post-strep nephritis, which is a kidney disease. Sometimes this garbage gets clumped up and stuck in certain lining in the brain, which causes it to dysfunction. And we think that that's a very plausible mechanism. So those mechanisms are important to understand, because when we talk about treatment, I'm gonna refer back to that in just a minute.
Thank you. I just want to, before we go, wow, what a wealth of knowledge. Thank you so much. But I just wanted to, if we can just take a pause, take a break from the physical.
Yeah.
And if I can ask Dr. Stern just to jump in there for a minute and talk about what these symptoms look like and his experience, how he sees them affecting school-age children.
Okay, great. So the first step is when I get a phone call and a parent is telling me that their experience is, this is a kid that a few weeks ago, no OCD, no anxiety. I'm calling you because the school or myself are finding that the kid is now, and we're going to talk about the different behaviors, but repeating the behaviors. There's different types of anxieties. He doesn't want to go to school. He's refusing to do things, behaviors that they've never seen. And in the realm of rigidity and realm of anxiety. So at that point, I will tell, and I think that's why a team approach is amazing, is I will tell them immediately, go for a strep test. Make sure it's not PANDAS. We have to rule out everything. And I always feel like first, for psychologists, we need to understand that we need to rule out any other medical issues before we get to the psychological issues. And I think we're going to talk about how come even after we find this as PANDAS, and we're treating the strep with antibiotics, how come we're still treating this with therapy? So we're going to talk more about that later. But that's the first step, is the onset of anxiety and OCD. The tricky part is that OCD is actually very hard. I'm not going to talk about different types of OCD, but sometimes it's hard to even differentiate if this was before the strep or after the strep, because OCD is very hard to pick up, especially if you don't know what it is. Anxiety is very very in your face. If he's avoiding something in regards to social situations, not making plans with friends, avoiding school. But OCD sometimes is very internal. He's always looking for uncertainty. Something amazing Dr. Gindi was saying is that there is research showing that the basal ganglia is affected when it comes to PANDAS, which is the part of the brain that actually does affect with OCD. Basal ganglia is one of those parts of the brain, not to get too into details, but it's that part of the brain that almost gives us that information that we completed something, gives us that reward when we finish something. So for example, for ourselves, if we have like a to-do list, or I have to prepare for this presentation, so during the day, I keep reminding myself, even in between sessions, I got to prepare for it, I got to think about it, and as soon as I'm finished with it, boom, I can move on to the next task. For somebody with OCD, they had that difficulty to be able to move on. So for example, they turned off the light, they left the house, and they said, did I really turn off the light? They don't get that satisfaction of, okay, I put a check on the to-do list. So they're missing that piece, and that then could turn into what they try to do after that, is to try to, we're going to talk about that's the obsession, which is the fear that maybe they didn't turn off the light, the uncertainty, and then they start doing compulsions to give them that certainty, maybe do rituals to make sure that, to give them reminders how they did it. Maybe let's say germs, they get a reminder, maybe my hands are dirty, they get a trigger, and then they have to keep watching till they get that feeling. They have to get a complete feeling, where most people, they get that click of, oh, I'm clean, I washed it one time, I can move on, and I'm clean. So that part of the brain is getting affected. And by the way, it's the same thing with tics. And tics is, OCD seems to be the #1 symptom when it comes to PANDAS, but tics is as well. And tics is something where a lot of times we're able to suppress certain movements. We might have an urge somewhere, or a little bit uncomfortable feeling. Tic seems to be where even the kid has an urge and it's an automatic response, the body automatic response, and is not able to filter out that it's not appropriate or it's not something that they should be doing right now, and it comes automatic without being able to suppress it. So it's very involved. It seems like basal ganglia is also involved later on with Parkinson's. Now, it happens to be nothing to be nervous about, because when people hear about the brain and affecting the brain, it's just more of a chemical imbalance. Same thing as if somebody developed a phobia, or let's say this summer a kid starts getting homesick in camp. There's going to be a chemical imbalance in their amygdala, which is the fear part of the brain, and now is going to start seeing camp as danger. That doesn't mean there's anything wrong. Chemical imbalances happen all the time, and we could switch that chemical balance. I think people get very nervous when they hear the emotional and mental health piece is getting affected but there's no like brain damage or there's any of that stuff. It's more of a chemical imbalance, neurotransmitters, and we could actually train, not only through medicine but therapy, we could actually help train and move that chemical imbalance into a right balance and correct balance. So some of the things you're really looking for is like repetitive behaviors. You're looking for a lot of reassurance. OCD, if you had to really define it, is the intolerance of uncertainty. So anything where they need certainty in regards to when they're writing a report, it has to be perfect, it has to be 100%. I need to know that this is the right way of doing it. If it's, for example, even just right, there's just the right type of behaviors where you start finding your kid that they bumped into someone and now they have to go back and repeat it, or they stepped on a line on the sidewalk and have to go back and repeat it. So you find almost like that just right type of thing. And also, if you find your kids, sometimes they're very embarrassed about it. They know a lot of times that doesn't make sense. So sometimes you'll find kids also just sitting there. And this is obviously, we have to look at patterns. If before the PANDAS, everything was fine, now you find your kid, it takes a long time to get dressed. They're in the bathroom for a very long time. A lot of times they might be doing a lot of things to make sure it's perfect. They're in the shower for a very long time. Or you just see them deep in every time there's a trigger, there's almost deep in thought. Some kids are like counting in their heads and doing all these types of rituals. So those are things you're going to be looking for. And like Dr. Gindi said, like with the tics, you have vocal tics, which is like clearing your throat, repetitive coughing, and sometimes you have like movements with like the twitching the nose, blinking the eyes. So these are things you're going to be looking for in those type of in regards to PANDAS, especially if it's onset and very quick.
Right. Wow. Thank you. Thank you,
Pleasure.
Dr. Stern. Okay. At this
Reggie's
moment,
good.
I'd like to welcome Miriam Berry. Miriam has brought her compassion and empathy to her over 2 decades of knowledge and experience helping school-age children with special needs as the director of search division within SBH. Miriam, I'd like if you can just talk about the field from the trenches. What do you see parents complaining about? What do you see the schools complaining about? Your experience with the PANDAS, and any information you can, general information you can give us.
So I would say that my clients are really my educators because they're the ones who come to me. A lot of times, I think it manifests itself most blatantly when a parent comes and says, "My kid was thrown out of school." We get those. I mean, I would just actually paraphrase the special needs. Our kids are really regular mainstream kids who get services from or might have learning issues, and that's who we help. We help a wide range of children in all of the yeshivot in our community, all of the mainstream yeshivot. A parent comes, "My child was thrown out of school." Oh, and you have to kind of parse out it's always about behavior. And sometimes a parent will say, "I don't know. The kid was great, and then one day he woke up with these crazy behaviors." And that's my moment where I say, "Okay, have we ruled out an organic cause? Is there something else going on?" Everybody assumes it's psychological, it's emotional, it's trauma. That could be any and all of the above. But when the onset is sudden, we really like them to rule out an organic cause. And I tell them, you might want to rule out PANDAS. There's Lyme disease. There are any number of medical conditions that can cause those types of behaviors. Most people think behavior is something's wrong with my kid and they're going to need therapy. Well, they probably will need therapy also, but it manifests there. I have parents who tell me as soon, and they've gone through this and child was diagnosed with PANDAS and they go through treatment and so on. I have one mom calls me up. She goes, "As soon as my kid starts acting weird, I go for a strep test." Parents are very intuitive and they have been my educators. I'm really loving this because Dr. Gindi, you talked about all of the medical stuff, and Dr. Stern, you talked about all of the psychological stuff and a lot of the medical stuff too. I have a great interest in neurology and neurological things. That's my personal thing. But it's really, we want parents to understand that it isn't always about behavior, and it's not about something's wrong with your kid. Something is wrong with your kid, but it's not necessarily the child is acting out because they want to, or something has happened to them. Sometimes there is an organic cause, and we like them to rule it out. We've sent many parents to rule it out because we just want to know, is this, because if we treat it with therapy, we're not getting to the root of it. We really need to get to the root of it. That's been our experience, and we've had a lot of parents come in with this. It was a parent who introduced me to this condition. And then as I started looking into it and so on and started doing my own research, I found that it is real. It is real. It manifests itself with these children, and it can be devastating. Thank you.
Thank you. Wow. Okay, so I think we're all hearing that sudden onset, that acute, in the PANDAS is a thing. If my child wakes up one morning and his behavior has changed, Dr. Gindi, if you can talk about what's the medical testing and treatment like?
Right.
What do I do first? Where am I going? How am I getting this
So you're
done?
reading my mind, because that was going to be my next sentence. Is parents will come in and say, they they come in, they're exasperated. They say, here's my child, I think my kid has PANDAS, I need a blood test. I said, oh, you got to back off a little bit, we have to get a history first. So the history really is, has he had a recent strep test? Oh, he had strep 3 weeks ago, 4 weeks ago, and within the past week or two he's acting bananas. I said, you don't need a strep test. Your child has, and they fit the criterion of all these mental health, not all, but some of the mental health conditions that we discussed. A child like that who has a documented strep, and the time course and the onset of the illness, of the behavior dysfunction, goes precisely with the strep infection, does not require a blood test. That child has PANDAS because he has the history to go with it. What's more interesting really is a child who, let's say, hasn't been to the doctor for 6 months or 8 months, and you look in his chart and he hasn't had a strep documented for a year, and that child comes in on a Tuesday in May, and you look back on his chart and he hasn't really been to the doctor, and he has this sudden onset. That child needs a blood, and you do a culture and the culture is negative. That child needs a blood test, because that blood test could be very, very instructive in determining whether there was a missed strep infection within the time frame that we're looking at. It can't be one from last year. It has to be something within the time course of within the several weeks to months of the onset of the behavioral disturbance. Moreover, we have to look for mycoplasma. It's very, very common. I see a lot of times where the parents come in from other physicians, whatever, they look for strep, but they didn't look for mycoplasma, and it's right there in your face. The child had maybe came in for a cold or a cough a month or so ago, and it really was a mycoplasma infection that wasn't treated, and that definitely correlates with the onset of the. So labs are important, but they have to be interpreted properly, and they have to be done in the proper scenario. Another thing is parents always, like, if let's say the child was diagnosed with PANDAS, and a week or two or a month or two or later they come back and they want to say, I want to know how the PANDAS is doing, let's do another blood test. I said, oh no, that doesn't help at all. Following the blood test does not help. Those blood titers, what is a blood test for PANDAS? It's basically telling you that the body has produced antibodies against strep. We have to understand that. If you had chickenpox 6 years ago and you do a blood test, you'll have antibodies against chickenpox. If you had strep within the past year or so, within the past year actually, and you do a blood test, you'll show that your body fought off a strep. It doesn't mean you have strep in the blood. This is all we get this all the time. I want to know if my child has strep in the blood. There is no strep floating around in your blood. If you had strep in your blood, you'd be in the hospital in an IV. You'd probably be in shock. Okay, it's an antibody against the strep that is in the blood that helps fight off the strep, and it indicates that you had a recent or not so recent strep infection or mycoplasma infection. So we don't follow the PANDAS patients with blood work. It doesn't help. That's another mistake that I'd like to demystify for parents about the blood work and how that works.
Thank you so much. Okay, so now we got the blood test
So,
and we understand that strep may be something here, but Dr. Stern, can you tell us what happens when they're in your office? What are we treating? If it's a blood test, if it's a biological disorder, what exactly are we treating when they get to you?
excellent. I just wanted, somebody asked a great question. I just want to go back to Dr. Gindi for a second. Somebody asked, is it from untreated strep or is it just
That's
from getting
great. That's a
from
wonder.
getting
I love that question, because the truth is, even treated strep can give you PANDAS, and we see it all the time. The kid came in on a Monday and he got strep. He got treated, and 2 to 4 weeks later, even though he took antibiotic, he's just manifesting, because what happens with strep is we want to treat the strep very early so that you don't manifest, so the body doesn't build up very high antibody levels against the strep. So sometimes the child is sick 3, 4, 5 days, even a week before they come in, or else the strep was incubating for a week before and the antibody levels are already that high. And as we described before, if the antibody levels either combined with the strep or attacking the host tissue, the brain tissue, that's the cause of the PANDAS. So we always want to treat the strep as early as possible to avoid these elevated antibody levels that seems to be mediating the disease. So
Okay,
you
great.
have been treated for strep, yes, and you can
Great.
still get PANDAS.
Okay, great. Thank you. So you were asking what to do once they get to my office.
Yeah, what are we treating in your office? I mean, if
Okay,
they're,
great.
if it's
Amazing. It seems like, and that's the big question is why PANDAS, after you treated it with antibiotics, why afterwards it progresses sometimes, or why it sticks around, especially the behaviors. I think the main thing is we're trying to, because what happens with OCD and anxiety is you actually start learning behaviors. Meaning, for example, the kid now is living in a world where he can't tolerate uncertainty, and then he starts trying to run away from uncertainty, trying to get certainty, and you start living in that life where, for example, he'll start avoiding places because they feel uncomfortable. He avoids germs because he's afraid that he's going to get sick. And now what happens is, let's say, I'm going to give you an example of how anxiety can develop. Let's just use anxiety. I think it's the same model as OCD. So, for example, if somebody's scared of an elevator, right, and whatever reason, just developed, they had some kind of trauma. They go to the elevator and they're a little bit scared. 1 through 10, they're a 4. And they're thinking, should they go on? Should they not go on? They go, you know what? I'm going to go take the steps today. Okay. And then what happens, the way it works is there's something called the amygdala, which is the fear part of the brain. It's not logical, but it sees that you avoided this elevator. So what happens is it now starts to think that the elevator is dangerous, because based on what you've avoided, it starts to develop a new way of approaching that elevator. So the next day you come and you see the elevator. So therefore the anxiety could go up to a 6 now, because now it thinks this elevator is dangerous because you've avoided, you accommodated, you've given life to the elevator. So let's say the same thing with a child. So let's say he's scared of germs, and now he washes 4 times in order to get rid of the germs. In his mind now, the circuits and the chemical balances in his brain thinks that's the way he needs that certainty for germs. So even after you got the antibiotics, he's already developed an accommodation or the need for certainty and a new behavior in his mind. Same thing as if families start accommodating. For example, let's say a kid will start avoiding school. And it makes sense. You have to work with the mental health professionals and the doctors in regards to missing school. But there's going to be a lot of things that are going to be accommodated now and reinforced. For example, running away from, I can't do school. I can't go to school. So then the kid starts to feel like I can't handle the stress of school. And then the anxiety gets bigger towards school, towards the stress of school. So even after the antibiotics, he's learned a new behavior or a new fear for something. So what you want to do is you want to make sure, as you're working with the PANDAS, also you want to make sure that he's not accommodating too much to the OCD till the antibiotics really kick in and be able to knock it out. The same thing is there's a lot of research that just show that even teaching a kid how to deal with OCD, even if it's PANDAS, you could actually rewire the brain a lot of times in many ways to reteach, because what it is the basal ganglia getting overexcited. You could actually teach it through your behaviors to start knocking it down as well. So there's a lot of connection between our behaviors and the chemical balances within what we do. So I would say make sure that we could be able to make sure the accommodations don't happen. Last thing is that, very interesting, one last thing is that when COVID happened, my hypothesis, and I know Shlomo maybe had a very similar experience. My hypothesis was that the people with germs OCD would be having the hardest time. They would be having a very difficult, meaning this is like their worst nightmare, right? Can't go 6 feet. I mean, they're living in this world. So I would call some of my OCD friends, and clients and how they're doing. And I found, and it wasn't just me, I had a lot of colleagues, that these guys were doing the best. They were doing the greatest. Why? Because their world is always uncertain of germs, and they know how to beat it. They've strengthened that muscle to beat it. So therapy a lot of times can teach you, even if there's nothing to lose, meaning you learn how to deal with uncertainties, a lot of certain uncertainties in life. You learn how to deal with facing your fears. You learn how to be able to deal with things that are a little bit uncomfortable. That's really what the therapy is teaching them it's exposure therapy. So you're teaching them to face it. So that's what's happening in my office, whether it's like touching something that has germs and holding back from washing. That would be the exposure, which is actually doing the opposite of what the OCD wants, is to show that the germs is not dangerous. So this guy he got even stronger than everyone else. It's the first time they're living with this uncertainty of
Right.
germs and everything else, and they don't have those muscles yet. So I think there's a lot to say about giving muscles and whoever it is and working together, because even the skills you get, whether the antibiotics are going to work, is nothing. I feel there's nothing to lose in regards to giving those skills and make sure the accommodations of the parents are not going in the wrong direction, which is then going to strengthen the OCD anxiety, even when the OCD anxiety is not there anymore.
So I hear two things that are really important there. One is that what starts with PANDAS can grow into something that's not even related to PANDAS anymore. That's just more of an anxiety problem that grew from it, as well as giving the skills of facing it and dealing with it and coping with it is something that's going to be healthy anyway, even if the antibiotics kick in.
And I will say, I should throw in, not to undermine, but I will throw in, of course, it's so fast and it's so strong. So we do have to have patience and sympathy for this kid. So, of course, it could be the kid's not ready yet. It's too strong, even the therapy. So it's up to the therapist and the doctor to evaluate that maybe he needs to right now, maybe we need to accommodate as much as we can right now. And we have to give that kid the balance. So we don't want to throw a kid into something that's too strong, but the therapy would evaluate that. I would speak to the doctor and to see, wait a minute, maybe let's wait for the antibiotics to kick in. Kid's not ready. He's having a hard time right now. It's been a hard 2 weeks. Or we feel like we won't accommodate, but we don't have to push him. So that's definitely, there are times when we say keep a kid home or not. You have to really be able to evaluate. Better, obviously, not to accommodate as much as you can, but we really don't want to stress or traumatize the kid as much as we can. So we have to really have that balance where we're not pushing too hard.
Right. Wow. Thank you. Miriam, I'm going to start this question to you, but really it's going to go to everybody. I think we all need to talk about it a little bit and get some insight. We know that PANDAS has been controversial. There's a lot of people on one side versus the other side. A lot of information and misinformation. What have you seen? Where's the trouble lie? And again, Dr. Gindi, Dr. Stern, we're going to go back to you with this as well.
So it is a controversial topic. I go to the National Institutes of Health. The National Institutes of Mental Health has a page on PANDAS. There are many doctors like Dr. Gindi who understand it, who have treated it. I think the most important thing for us as advocates is to help the parent understand that your child is suffering from an illness. Chas v'shalom, if your kid had diabetes, you would treat it. If your child had something else, you would treat it. It's parents, and I think some parents are relieved because they don't understand how this wonderful child kind of turned crazy overnight. And I guess I'll use the word crazy loosely, but really the child has changed overnight. And we also have to intervene with the schools. We've had kids thrown out of school because of PANDAS behavior. And we really have to help everyone understand this is an illness. It is real. It's hard for me to deny what I see with my eyes. It's hard for parents to deny. And when they do have a solution, and many parents have pursued other solutions. They've gone for therapy and there is an organic cause that needs to be addressed. When you address the organic cause, then you need the therapy to kind of break those habits. Schools need to understand what's going on, and it is an uphill battle. I know we've had a lot of controversy about it. We know that a lot of people didn't believe in COVID either, okay? This is different. COVID was a pandemic. This is not. It's unusual. It really is. It's an unusual manifestation of an illness. And like I said, I know what I see. I know what I see, my parents who've experienced it, and for many parents, it is a relief. It is a relief because they think their child suddenly went bad. My child is now bad. No, their child is not bad. Your child is not bad. We need to fix this. We can help you. And just awareness is very important. Dr. Gindi's right. There isn't a lot of data. There isn't a lot of research. I would love to see that. There are peer-reviewed studies, but very few. I looked them up. Very few peer-reviewed studies. We need to study it more because it's new. It's new. And science likes clear answers, clear questions and clear answers, and we don't have them here. This is a very hard scientific topic, but as everybody who's ever faced anything difficult knows, sometimes we just don't have hard and fast answers. If science and medicine was all that cut and dry, we'd all be healthy. We'd all be healthy and nobody would be sick. But we know that that's not the case.
Okay, thank you. Dr. Gindi, can
Right.
you shed a little light medically on the controversy?
Absolutely, and I want to address. I've been looking at some of the questions that have been coming through, and they're actually quite good. A lot of the parents are really would like some answers on treatment, medical treatment for pandas. So I think it's important that we understand that it's a two-pronged approach. It's the mental health approach, which includes, which the word was not used yet, parenting. Parenting counseling is critical in getting these kids to behave properly. So I always recommend that the parents get, whether they're going to go get the kid therapy or not is a separate issue. If it's severe enough, yes, the kid might need to go into therapy. And another word that hasn't been used on the medical health side yet is CBT, cognitive behavioral therapy, and parents have to be aware that such a thing exists. So CBT is very important, and parenting counseling is critical in getting these kids, and not to empower the children, not empower them, but not cause the behaviors to become more firmly entrenched. This is what was discussed earlier. We want to be supportive and not and reinforce the negative behaviors. That's important. But from the medical side, from my point of view, as the doctor, there are a lot of things that we can offer the patients from the medical treatment. Antibiotics were mentioned, but again, there's no good studies to say how long these antibiotics have to be given for. So I tend to follow the Susan Schulman approach. Susan Schulman was a doctor who really was at the forefront of PANDAS treatment going back 10, 15, 20 years, and she was a close friend of mine at Maimonides. And her approach, believe it or not, was very ahead of its time and prescient, and I follow it, and it really, really works. And her approach is Zithromax. Now, when a patient comes in and says they think they have PANDAS, we're not sure, or even if it is PANDAS, I said we're going to start with a trial of therapy. A trial of therapy means 2 to 4 weeks of Zithromax, and then we either bring the child back or have a conversation. And we are expecting an improvement at least between 20 to 30, 40, 50% within that short period of time on the medication. If that in fact happens, then it's a home run, because we know that the child will get back to baseline behavior in a very short period of time. I don't believe in long-term antibiotics for 6 months to a year, which is unfortunately what some people are doing. I'm not doing that. I'd like to get the child back to baseline behavior in a short period of time. It could be several weeks, it could be a month or two on the Zithromax. And I usually wean the medications down at 2-week intervals. That's just my approach. I don't know that there's any literature on it. It's not scientific. As I was trying to explain before, we're in murky waters, but it does work. It works. In my hands, it works very, very well. And the side effect profile is extremely, extremely low. If Zithromax doesn't work, sometimes we use amoxicillin, augmentin, other antibiotics. There's no rhyme or reason. But we should understand why the antibiotics work. The antibiotics work. There's 3 reasons why the antibiotics work. One is you might be having a strep that's sort of deep-seated and in in a scar tissue somewhere, or in the tonsil, or in the sinuses, that need a longer course of antibiotic. That's one theory. I'm not so sure I'm a big proponent of that theory. The next is that you're preventing the child from getting strep again, which actually is very a useful way of looking at antibiotics, especially when, as I said, we're using other diseases to model PANDAS against other diseases. So we're modeling PANDAS against rheumatic fever and rheumatic heart disease. Patients who have rheumatic heart disease go on antibiotics for years. They take penicillin every day for years because they can't afford to get another strep infection. So we're really actually preventing the child to get another strep infection, because if you get another strep infection on top of a vulnerable nervous system, you already had a severe PANDAS attack, and you got another strep, you're gonna it's like you're gonna be in orbit. It's gonna be a terrible, terrible situation. The third reason that these antibiotics work is my real personal belief is that they actually the antibiotics hook onto these these immune complexes that are floating around, this garbage that we spoke about before, and allows the white blood cells to come and engulf them, and more efficiently, and to get rid of the garbage from the central nervous system, from the bloodstream, wherever it is. So again, I use that. The other really important modality is going to be anti-inflammatories like ibuprofen, which we use in short bursts, maybe 3 to 5 days here and there when you get an exacerbation, because we spoke about PANDAS being something that periodic. It comes and it goes and it comes and it goes. The child gets better and it comes and it goes. And the third one, which we never use, I want to make sure that everybody hears me. You never use steroids as an anti-inflammatory for PANDAS. I hope some doctors, it's just not good to do that. And the other thing is, there were some questions about intravenous immunoglobulin. So that is really not on the I would say cutting edge, but not standard treatment to use intravenous immunoglobulin and plasmapheresis. I see it on the screen there. I'm fully aware that some people are doing plasma. Now, plasma, these terms are being thrown around and bandied around like it's like taking candy. This is not taking candy. This is a very invasive procedure. Plasmapheresis is you take the child's blood and you totally get all the blood out of the body and you filter it out, try to get the immune complex out, and you put it back into. It's a very, very invasive procedure with complications, side effects, etc. And it should be reserved. Maybe I have none of my patients have needed it. I can say because in my hands, I find that in response to the treatments, especially with the mental health piece and the antibiotics and the ibuprofen, we've had and the very important also is the psychotropic medications. And when Zithromax and these antibiotics not working, there's no reason that a child should suffer severely with anxiety, OCD, and leading to depression and other things without a little bit of psychotropic medications. And low doses works unbelievable. I've seen very, very favorable results with low doses of psychotropic medications in layman's terms, like, whatever, fluoxetine, whatever the medication is. And I do that all the time. And I stopped referring these patients to psychiatrists. First of all, you can't get an appointment with a psychiatrist, and they don't really, they're impossible. And a little bit of psychotropic works beautifully. I want to just finish. I know I'm taking up everybody's time, but I want to say that the prognosis, we really should talk about prognosis. It's very important because if treated early, these patients get better very quickly. I see them within 2 to 4 weeks, sometimes 50%, 75% better. If you wait too long to make a diagnosis, if you waited 2-3 months, it takes that long for them to get better because a lot of the behaviors, as Benji said, are reinforced. And you're reinforcing the abnormal circuitry in the brain for the anxiety, and then you're reinforcing the anxiety, and then you have to do CBT, and you have to do a lot of counseling to get rid of the anxiety because it's so ingrained in the system. So it's not only the PANDAS, but it's the neurologic response to the PANDAS that it makes it just that much more difficult if you don't diagnose this quickly. But with a quick diagnosis, it really, the relapse rate is quite high. When they get strep again, they tend to relapse pretty quickly. And also viruses can do it because other things cause high inflammatory levels in the body, which causes the central nervous system, which is vulnerable. They have a vulnerable central nervous system that tends to respond to high inflammation in the bloodstream. One last thing, and then I think I want to make sure that people understand that PANDAS can also be manifest in patients who already have these chronic conditions. So just because if a child is a chronic anxiety child or an ADHD child or a child who has some tics or a child, and then they get PANDAS, it really elevates them. Again, a vulnerable nervous system. So when you treat them, we always speak about getting them down to what we call baseline behavior. If their baseline behavior, if they have mild anxiety disorder, you're not going to get rid of it down to the bottom. You're just going to get it down to where it was before. The same thing with phobias, etc., OCD. And so, but these children with vulnerable nervous systems are more susceptible to getting, because they have vulnerable nervous system. So any little dysfunction causes them to escalate quite rapidly. So that's how I, that's that.
Thank you, Dr.
Right.
There's so much information. Wow, it's great. I really appreciate it. I want to finish up. I know people are probably anxious, but Benji, I just wanted to if you can talk about. I know in my experience dealing with PANDAS kids, a lot of times there's a balance between treating the anxiety and maintaining the self-esteem. The self-esteem can get so damaged through
Yes.
an experience like this. And how do we treat and maintain the self-esteem as the most important component so that doesn't get, long-term injured?
That's an amazing question. Just first question I have is, Dr. Gindi, are psychologists also impossible, or we're good? We're okay?
You're much more available than the psychiatrist, that's for sure. But again, I really think that we a lot of the times in the age 3 to 7, 8, 9, we really should be focusing on the parenting piece of it, not so much putting the child in therapy. I mean, I don't know if that's politically incorrect to say, but
not at all.
I think that parents, because when you put the child in therapy, you're giving the child a message that I'm broken, I'm something wrong with me. I think that the PANDAS is either going to burn itself out with time anyway, and the only thing the parent can do is more damage by reacting to the behaviors in a very damaging way, in a self-defeating way, in a disparaging way, and giving the child low self-esteem. And the parents are the ones that need the counseling, not so much the children.
So okay, that's great. And so I will tell you, I try very hard to make sure that the therapy is something that is veered towards bringing up the strengths of the child. One of the first things I ask in the intake is to ask, what are the strengths of the child? What is good about him? And when the kid walks in, and I talk about my weakness, other people's weaknesses, and I say, we're here to overcome weakness. That's our life. That's what we're here for. I call myself a coach. I don't know if there are other people, but that's and a coach is somebody even top. I bring sports players and I say LeBron James has a coach. Everyone has a coach. Right now we all have stuff to deal with, and especially if it's OCD, we could talk about. I think of a kid already knows, he's already embarrassed. He knows something's wrong, so not treating it, I think, exasperates. I find when parents are trying to help the kid hide a disability, I find there's even more stigma, and there's even more issues with self-esteem. I worked in academia. I worked in different schools where, if you're trying to hide that, something that they have, or even a physical disability, something like that, the kid feels it. But when he comes to school every day and say, I'm okay with this, this is who I am, and this is what I'm struggling with, and it doesn't change who I am as a person, it's just a side thing. It's just a side. So I think that really helps. And that's definitely, I never want a kid to go to therapy and feels worse about his self-esteem. So that's the number one thing. And I think the parenting part, people were asking, what's the parenting piece? The parenting piece is, and there's a lot of research, and what I do is teaching parents how to be able to deal with it. I'm giving you just like a very simple example. What to do. Parents are not sure what to do because their instinct is to help the child. Let's say a kid keeps asking, am I contaminated with germs? Or, the trip tomorrow, maybe something bad's going to happen tomorrow, right? And what parents want to do is keep answering the question. What I teach parents is just a simple thing, is this kid is looking for reassurance and he's not going to get it, and you're going to keep answering, and it actually makes it a lot of times worse because you're accommodating that certainty. So just a simple tip of helping the parents be able to be a teammate with the kid. And we say, okay, you're Mr. Fear. And we actually, it's not the kid in therapy that's really the problem. It's this Mr. Fear, we call it, or you call it this monster, this OCD monster, and whatever you want to call it. And we externalize it from the child, and we say, this thing is telling you that something bad's going to happen, and we're not going to listen to it. And I have the parents actually hold their hands and say, we're going to beat this. I know it's really strong. It's not. And then the kid feels more validated. So if a kid feels you understand him, and we're saying these are all your strengths, and we want you to be able to overcome this and make it more like a battle, make it more like this is something outside of you, this is not you. I find kids can actually feel very validated. I have kids. It's a funny thing. Kids nowadays, I think it's a new world, I have kids talking to each other about, do you go, like I
Go-
have high school kids. I have parents who call me and say, oh, my son told me that he wants me to call you to tell you to come because the kids in this class are coming. It's an interesting thing. It's a whole new world. I had that. We started on Mag and David also just ago. I think kids are looking, it's a new, and I think the type of therapy is much different. The type of therapy used to be, it was focused on the problems. I think now there's a lot more on positive psychology, there's a lot more on building the children up and try to keep it a very positive experience. So
Right.
that's how I would present that. It's great.
Right. And having parents not respond frustratingly in a frustrating situation,
That's
right?
right.
How to help the
Parents,
parents stay.
parents are a very, very big part of this
That's
because
right.
as any parent who's ever been a parent, you know that if something's wrong with your kid, that generates a tremendous amount of anxiety, a tremendous amount of uncertainty. What do I do? Am I doing the right thing? Should I be doing this? Should I be doing that? Well, this one tells me do that one, and that one tells me do this thing. Working with the parents, really, parents need reassurance as well. We can beat this. Parents need reassurance that this is a manifestation of an illness. We treat it with medicine. We treat it with therapy. We're going to treat you with therapy because you also need to calm down. The hardest thing is watching a child suffer from anything, whether it's a physical disease or this type of thing. It is really very painful. That's what gives parents the gray hairs. That's what gives us all the wrinkles. It's the parenting part. So helping parents, I think that's both of you, both Dr. Gindi, Dr. Stern talked about the parents, how important they are. And yes, this is not only on the child. What parents do will have great impact on how the child weathers it and how the parents and the entire family, parents are the standard bearers in the family. They're the ones who set the examples. You set the model. If you're managing this child okay, everyone in your family is going to manage okay, and it will really bring a lot of peace and tranquility to a very difficult time. So the parenting piece is very important.
Well, will we
Right.
have time for one comment, or I know we're running out of
Sure.
time? There's a
Sure.
really quick comment. I just want to give one example. I saw a bunch of families after, there's nothing with PANDAS, but after October 7th, they were in Israel, Eretz Yisrael at the time, and um, and there were very different experiences. I was meeting some of the kids who were dealing with the sirens and different, and I found that the kids, I was trying to differentiate which kids. Some kids came back very frightened, and some kids, like, it almost like I didn't realize there was something different. And I felt it was really around, like, the kids that were in hotels. I found that were in a shelter with other, a bomb shelter.
Oh, what happened?
We lost your voice. No, we lost
Yeah.
your voice, Benji.
We can't hear you.
Benji. We lost you, Benji. Oh,
Hey, thank you. But I found that the parents who were maybe in an apartment or they were dealt with it together, and they created a different spin to it. They created maybe, okay, there's a siren, this is what we do, like almost like a fire drill. It was the way they dealt with it, a lot less anxiety. So I think a takeaway message is a lot of hope. There's a lot of treatments here. We're talking about PANDAS. It's treatable, it's workable, and we don't want to create more anxiety on the child, because part of it is more anxiety, the harder it is, the deeper the kid can get into it. So I think it is important for the parents to just be aware of their own anxiety and realize we're going to take care of this. There's work to do, and there's a lot of treat. And I think you have to use trust the school, trust the people involved, and trust the team. And if it's a teamwork, I think there's a lot of success. It can go very quickly. Hopefully, that was at that shot.
wow. Thank you. Tonight was a wealth of education and information. I'm just, watching the comments come through. People really appreciate it. Thank you to all our panelists. Maybe we'll be back again with some follow-up. I want to reserve the right to make a second of this. It was fascinating, at least to me. We want to thank you all. And I guess I'll wish you a good night until next time.
Thank you very much.
Thank you.
Thank you.
Okay.
Thank you for giving us the opportunity.
You're up.